It's usually difficult to know whether the mic is working from this end. So good morning, everyone. We start by thanking the organizers for inviting us to give a talk this morning on what we are learning from post-trial and demonstration projects. This talk I'm giving on behalf of myself and Dr. Neri Mogo. Those are our disclosures. Just for the sake of people who may not be very familiar with the field of PrEP, or pre-exposure prophylaxis, I'll start with a brief background. So the hypothesis we started with was whether PrEP would reduce HIV susceptibility when taken by HIV and infected persons. This concept of pre-exposure prophylaxis is not new. It's been used a lot in sub-Saharan Africa when we talk about malaria, that if you're going to a malaria endemic zone, then you're advised to take malaria drugs which are used as treatment for pre-exposure. Then we had PrEP efficacy models, animal models, that supported that when used, PrEP could help reduce the risk of HIV acquisition. And also ARVs have been used in PMTCT in a way which is more like pre-exposure prophylaxis. So the big question we had was, can the same drugs that revolutionized HIV treatment work to prevent new infections when used as chemoprophylaxis? There are many drugs that have been used, but mainly two primarily. One is which is tenofovir, the other one is Truvada. And we found that the evidence is solid. Multiple studies in different settings in different countries have supported the hypothesis that pre-exposure prophylaxis could work to prevent the risk of HIV acquisition. One of the landmark studies that I was involved in is the Partners PrEP study, which was carried out in Kenya and Uganda. Our study population was HIV discordant couples, and efficacy for Truvada was 75%, and for tenofovir was 67%. So that was highly protective, and there are also additional studies like the TDF2, which was conducted in Botswana among heterosexual men and women. And you can see the efficacy there at 62%. Then the IDU study in Thailand, that was done among injectable drug users. Again, the efficacy there is 49%. Then the IPREX study, which was actually one of the first studies to demonstrate efficacy of oral pre-exposure prophylaxis, gave an efficacy of 44%, and then the Caprisa, the microbicide gel, had an efficacy of 39%. So this is evidence solid. There are some studies that have given contradicting evidence, but we know that the reason why these studies have given the contradicting evidence has solely rested on the issue of adherence. That's why we always talk about adherence as the Achilles heel of pre-exposure prophylaxis. So that was our question. But now the question has changed. It's not whether the drugs can work, but how can these drugs that have revolutionized HIV treatment work to revolutionize HIV treatment? There are several questions that need to be answered. These questions need to be answered as we move from the clinical trials to the real-world settings. One of the key questions that we want to ask ourselves is who do we target? Who do we prioritize? There are populations that are higher risk of HIV acquisition in various settings. And these populations include those who cannot negotiate safer sex, those who are willing or unable to use condoms, those who have a HIV-infected partner who may want to delay or decline ART, HIV serodiscordant couples, young men who have sex with men, young women in many settings, also in sub-Saharan Africa. And one thing that we know, and that is a term that was coined by Dr. Neri Mogo during the AIDS 2012, is that PrEP is not for everyone, it's not forever. is going to be for seasons of vulnerability. To give an illustration, when we look even at some of the high-risk populations, let's say sex workers, for example, even among sex workers or HIV-discordant couples, there are subpopulations within those groups that are higher risk than others. And even among those, there are times that they are at higher risk. For example, for discordant couples, they may be at higher risk if they are young. They may be at higher risk if they want to have children. For sex workers, we've had in our country that when sex workers are beginning sex work, that period is a period that they are at higher risk. They're not able to negotiate condom use. So that's one of the periods that then PrEP would come in. So the reason why we would want to target populations at higher risk is because we would want to make this intervention cost-effective. And for the intervention to be cost-effective, we need to target those at higher risk, those who are motivated to take PrEP. Now we have data coming in from several studies that is showing that validated risk assessment tools could be used by providers to select this higher risk population. Actually, somebody was asking me over breakfast, how do you identify higher risk population? So very simple validated tools could be used to do this. I want to just share a bit about a tool that we've used in our partners demonstration project. And this tool was developed from our previous studies. And what we have seen is that there are several characteristics that put the HIV and infected partner at high risk of HIV acquisition. And the components of this score include young age, fewer children, lack of circumcision of HIV and infected males, high plasma viral load of the HIV-infected partner. And for our partners demonstration project, we were trying to see whether it was feasible to target these couples with a risk score of more than 5. And this risk score of more than 5 also translated to an HIV incidence of more than 5% in a year. So then we move to the second question. Efficacy was demonstrated in clinical trials. But does this translate into effectiveness? We all know that in clinical trials, the setting in a clinical trial is usually very rigorous and may not be replicable in a real-world setting. So the question was, do the people, or does PrEP work outside a clinical trial setting? And emerging data suggests that PrEP works outside clinical trial setting. And I'll take you through some of the data. I'll start again with our partners demonstration project, which is an open-label prospective interventional study that is of ART and PrEP. And this project is being carried out in 2 settings in Kenya and 2 settings in Uganda. And the overall goal is to evaluate how the scalability and effectiveness of PrEP when used as a bridge to ART. And PrEP and ART are not used in isolation. They are working as a part of a prevention package that includes counseling, adherence, and other interventions. The uniqueness of this project is that PrEP is used as a bridge. That PrEP is offered for 6 months after the HIV-infected partner initiates ART. And the reason for this is that we estimate that the HIV-infected partner using ART for 6 months will be able to achieve viral suppression, and then we are able to, it becomes more cost-effective to just rely on ART. And this strategy has been supported by mathematical modeling, that it will be highly effective if PrEP is used this way. So the results that were presented recently at the Correlates conference by Jared Beaton, who is the protocol co-chair, is that if we did not have any intervention within the population that we enrolled, the high-risk population, we would have predicted 39.7 HIV infections. However, only 2 infections were observed, giving a risk reduction of 96%. This was very, very exciting news because we are seeing that using this PrEP as a bridge, it's possible to actually eliminate HIV acquisition among HIV serodiscordant couples. This is much, and this is much greater than what has been observed in other studies. Recently, again, in the CROI study, in the CROI conference, a study known as PROUD was presented, which was conducted in England among MSM. And this study randomized 545 men to immediate oral PrEP versus delayed for 12 months. And one of the key outcomes was HIV incidence. And in the immediate arm, the HIV had an incidence of 3 infections, and in the delayed arm, 19 infections. This made the DSMB to stop the study earlier than scheduled and translated to a risk reduction of 86%. And by the time this study was stopped, it had only enrolled 10% of what had been planned to be enrolled. Again, it's noteworthy that in the PROUD study, the population again was higher risk MSM. The characteristics include that 10% had syphilis, 40% had used PrEP, and 74% had used recreational drugs. This again affirms that PrEP is effective. Another study that was also presented at the CROI conference is IPAGE, and I'm sure some of the investigators for either PROUD or IPAGE may be here. Again, in this study, 414 men who have sex with men were randomized to either Truvada on demand or PrEP on demand arm. And the incidence in the on-demand arm was 2 compared to the incidence on placebo on demand. The regimen used here was that they would take 2 pills, 24 hours to the sexual contact, or to the anticipated sexual contact, then take another pill after 24 hours, and a 4th pill within 48 hours from the first pill, translated to about 4 doses for every sexual contact. This again had a high efficacy of 86%. Again, this was very good news, which led to the DSMB stopping the study early and advising that the placebo arm to be also be put on on-demand PrEP. All this is very good news that's showing us that in the real world, that when we mimic real-world situations, then PrEP also provides efficacy. This has been stated and restated many times, and not only in PrEP, but even in other drugs, that a drug works when taken. It didn't seem very obvious when we started seeing emerging data from various trials, and we started asking ourselves, why would one trial show efficacy and the other one didn't? And as a bonus, I've brought this older slide from the PrEP trial, which shows dose response or dose efficacy relationship. But the higher the efficacy, the higher the adherence, the higher the efficacy. I mean, for the studies like FemPrep that I have not put here, the amount of drug shown or that was found in blood or plasma for those participants was much lower. We have gone further to examine the seroconverters that have been found in the partners demonstration project. The 2 seroconverters did not have evidence of PrEP in their plasma, and they both had reported breaks in PrEP use. And this can be seen from the Jared Bitten's presentation in CROI 2015. Again, in IPAGE, the 2 seroconverters had stopped using PrEP months before testing positive. We have done qualitative work in the demonstration projects. We have done and we continue to do qualitative work because we want to learn as much as possible how this strategy can be rolled out in real world and scaled up. What participants say is that PrEP provides additional protection, which is a motivating factor. That they may be having additional things that they're doing for protection, but it provides protection, it reduces anxiety. For couples, it increases communication, because when we have couples coming to our sites for the first time, they have been tested, they are discordant. They're usually at a situation where they don't know what next. But they come with this tool, there's this new biomedical intervention, and it's quite exciting for them, which increases even their self-efficacy, and they're able to resume their normal relations and intimacy. And this is a quote taken from IPREX open label extension, that just to show what the MSM say, that we all have our sleep sometimes. And sometimes we don't take the safest route. So PrEP comes in to fill in some of those gaps. Then the other question that the implementation projects are asking is, or asking and trying to answer, is do those who might benefit most from PrEP want to take it? From our demonstration project is that more than 95% have accepted to initiate PrEP. Out of all those offered, 95% have accepted to initiate PrEP, and adherence is high. And then for ALT, because in our context, PrEP is being offered as a bridge to ALT. Again, 80% have accepted to initiate ALT, with 90% reaching or achieving viral suppression. And for 48% of follow-up accrued to date, couples have used PrEP alone prior to initiating ALT. 27 have used PrEP and ALT overlapping, and 16% ALT alone. In a demonstration project in San Francisco, there are 90% of blood samples had tenofovir detected in the concentration expected to provide 90% protection. Again, this is exciting news because, again, it shows that there's good adherence outside the clinical trial setting. Then the next question is about adherence, whether the people who require PrEP take it often enough. But what we are learning from open label extension studies, especially from MSM, is that you don't have to be perfect. Although PrEP is recommended for daily use, it has some forgiveness in the real world for those who do not take PrEP well enough. From MSM data, we are seeing that those who take more than four and more doses within a week provides about 100% protection. This data, though, I want to throw in a caveat there. This is among MSM. So we do not have comparable data from the heterosexual population. We also know, and we are learning from our demonstration and open label extension projects, that not everybody who is offered PrEP takes it. In Partners PrEP, at enrollment, 11% initially declined. In IPREX open label extension, 24%. In Partner demonstration project, there's about 9% of follow-up that does not have either PrEP or ALT. Then in the San Francisco demonstration project, 40% of those eligible declined at enrollment, citing not being interested to be in a research study. This again is data mainly from trials that can help us as we understand rollout of PrEP. There are several correlates of low adherence in oral PrEP trials. One of them is young age. Second one is not being partnered. For our demonstration projects where we have discordant couples, we see that discordant couples many times perceive themselves at higher risk, which most probably drives the adherence. Those who have less sex also then have less adherence. Alcohol use also affects adherence. Again, when participants do not make it for their appointments. This may look easy, but I know we have also learned this from our ALT clinics in our settings in sub-Saharan Africa, where participants do not honor their appointments, then they are not able to come for their refills, which translates to low adherence. And there are also several barriers. One of them is stigma. There are participants who come to our clinic, for example, and they do not want to carry the PrEP in the bottle. They ask whether it can be put in something else, because when they see the bottle, they say, if somebody sees me in a public transport or in a train going home, they'll see this is an ALV, and it may disclose that I'm either HIV infected or in a HIV serodiscordant relationship. And then there is also lack of knowledge on PrEP and shame about asking prescribers. And this was reported about in Boston, that 76% of men in Boston receiving PrEP were interested in taking PrEP, but 33%, that's a third of them, did not feel comfortable in talking to prescribers about it. Then again this morning we were having a discussion with a colleague from Zimbabwe, and one of the questions was asking, are there risks in having PrEP? Are there risks in taking PrEP? And there are two risks that we'll attempt to discuss this morning. One is risk of risk compensation, and then the risk of resistance. But just to start off, is I'll say that risks exist, but the greater risk is not doing enough. One of the things we know is that if there was a substantial increase of risky behaviors among those on PrEP, this could offset the benefits of using PrEP. However, the issue of risk compensation has been a lot of it has been more of theoretical discussions, but we do not have solid data to support this. I want to highlight two studies, one of them Partners PrEP, which I was involved in, and IPREX. So in both IPREX and Partners PrEP, unprotected sex and STIs were less common over time, suggesting synergy of ongoing risk reduction counseling around PrEP. So we are saying that in these projects, we provide PrEP, but it's not as a standalone. We provide PrEP with risk reduction counseling, condom. We also offer circumcision for the HIV and infected males. We also offer treatment for STIs. So it's within a package of interventions. So as you see then, within time, the STIs reduce, which is an objective marker which points out to that then the contacts or the risk compensation is actually not there. Then I want to highlight a Partners PrEP study. In Partners PrEP study, it was a 3-armed study. We had a placebo arm, a tenofovir arm, and a Truvada arm. And this was a double-blinded study. We announced our results in July 2011. Follow-up continued in an open-label fashion. And when we looked at risk compensation, again, you can see that in terms of STIs and condom use, the condom use did not change, which again suggests there was no risk compensation within one study, one same population. What about the issue of resistance? This issue has been discussed many times, has been asked multiple times. Wow, I have 5 minutes, okay. So resistance occurs when antiretrovirals are used, and PrEP data emphasize that there may be risk. But the risk we have seen, it has been rare, and mainly has been found among those who had acute infection at the time of enrollment. And it's also dwarfed by the efficacy. So when you have, for example, in Partners PrEP, we had 2 incidences of PrEP resistance, which went off over time, and compared to, through modeling, to the 123 HIV infections averted. And this has been modeled to contribute to only a fraction of what of community ALT resistance. I'll move a bit faster now. So the other question is about deliverability. So how do we deliver for maximum benefit? Which effective combinations do we use? There are questions about costs. There's a question of HIV testing. In the clinical trials, for example, HIV testing was done monthly. In the demonstration project, we are doing it 3 monthly. But you have a question whether that can even be stretched further. There are several demonstration projects that are going to help us answer these additional questions. Questions of cost, for example, is a question that needs to be answered because this is what we'll go with to the policymakers. We'll provide more information on resistance, on risk compensation, and there are multiple studies. I'll not go through them, but I'll advise you that you could visit the EVAC website. They have more than 10 studies that are being done in areas of limited resource settings. That's in Africa, Brazil, India, and other countries. And they also have listed studies that are being done in America, Canada, and other countries. There's also room for innovation. For example, in our partners demonstration project, just as a way of improving deliverability, we are trying to see whether we could also tack in, have HIV self-testing so that we reduce deliverability cost where HIV and infected partners would test themselves at home instead of coming to the clinic. And what we are finding, and we presented this data in R4P, is that it's feasible, it's highly acceptable. I think 98% of participants have accepted. And we are also trying now to go further to dig into issues of costs, because at the moment, HIV self-test kit itself is expensive, but we are going to see how to model and see how our cost would pan out if it was cheaper. Then we still need to do more work of how we combine HIV prevention tools for maximum benefit. And there are multiple ways that we could do combination prevention when we add PrEP onto it. And that's how our prevention toolbox looks in 2015. This was not the same way it looked 5 years ago. It's looking quite good. We hope it will add more tools to it, including the vaccine and other tools. Just this illustrating that combination prevention is highly effective. Combination prevention that we have used in our studies, for example, in Partners PrEP study, reduced what we would have expected among an ordinary cohort of HIV discordant couples, 10 to 15 to 2% per year, in those who are on the placebo. So even without a biomedical intervention, this can be very helpful, having other combination prevention tools. PrEP reduced to that, and in the demonstration project, this has gone lower from 0.5% incidence per year to 0.2. But again, PrEP is being delivered in the context of combination prevention. We also need to look at innovative ways to deliver PrEP. For example, in the discordant couples, as I mentioned, using PrEP as a bridge to ALT. Then there are other ways about risk-targeted PrEP, which adds to ALT. Then using demonstration project, delivering both PrEP and ALT must be maximized. We have learned a lot from the PMTCT field, but in many ways which could be replicated in ALT and PrEP for prevention of sexual transmission. I'm coming towards the end. I know I'm out of time, so I'll run through this. So what are the next steps? One of the next steps is advocacy. So for advocacy, we need advocates to go out, give personal testimonies, and I'm happy. So one EVAC advocate here. So this needs to go out, roll out, tell people about the PrEP, answer questions, educate people, educate providers about PrEP. There are still many providers in these settings who are not aware of PrEP. All this needs to be done so that this will help push the PrEP agenda and help scale up. Policy, as we do advocacy, the advocacy needs to go hand in hand with policy. I'm happy to note in my country, Kenya, that we are making good strides. The Kenya HIV Prevention Revolution Roadmap includes PrEP for HIV serodiscordant couples as one of them. And then we also need to talk about guidelines, and WHO has issued guidelines for discordant couples, and many countries are also coming up with their own guidelines for PrEP. We also need to remember that PrEP is not one size fits all. Today, the oral PrEP is only the first generation. We need others. We need other tools. We need the vaginal film, vaginal ring, which hopefully we should get results this year. Injectable, it's also another way that we need to, that's needed. Just think through about contraceptives. In the field of contraceptives, we have multiple choices for contraceptives. And again, we have multiple choices. And we also know that even in those choices, people are not always perfect in consistency. Even among those who use contraceptives, if you ask them, it's not usually perfectly used, but it's still able to have a benefit. We also need to move more and develop better strategies, including having the current prevention strategies or antiretroviral-based strategies to add, to make them multi-purpose, to have maybe a contraceptive component. We are coming towards the end, and then when you look at PrEP and oral contraceptives, both of them are very similar in multiple ways. Initially, both oral contraceptive pill was used for treatment of menstrual disorders. Oral PrEP was used for ALT treatment, and is still used for ALT treatment. They both offer individual control for prevention. There are concerns about sexual behavior. There are concerns about adherence. They were there even during the 70s when we talk about oral contraceptives. Perfect use is ideal, but in real world, it has to be balanced with individual preferences. So, in conclusion, what we are learning from post-trial and demonstration project is that post-trial and demonstration project affirm that PrEP works for prevention of HIV acquisition. That when taken, they work. You don't always have to be perfect to be good. PrEP is wanted, but it's not forever, not for everyone, and not one size fits all. There are risks in doing, but there are greater risks in not doing enough, and it's time to deliver. I think now this is a rallying call that it's time to deliver PrEP, and there's need for innovation. The reason I've put the puppets there is that we have used this kind of innovations to recruit couples into our setting, so need for innovations even in delivery. So thank you very much. I think this is an exciting time where we can be able to see the end of HIV in not too distant future.